Friends, I'll tell you about my patient. She was a 60-year-old female. She's allergic to penicillin. She's a ASA3, and she's coming in for a Da Vinci robotic hysterectomy with salpingo oophorectomy related to abnormal bleeding, pelvic pain, and adhesions. The surgical time's estimated to last 2 to 4 hours. So our patient, she's 5 foot and 70 kilograms. Her past medical history is significant for arthritis, sleep apnea, stable angina, COPD, hypertension, hyperlipidemia, anxiety, and depression. Her home meds are lisinopril, atorvastatin, fluoxetine, and nitroglycerin PRN. So she's stated that she's not always compliant with her medications because she's homeless. Here lately, though, she's contacted some resources and she's been able to get her medication. Um, so, social history, she's a current smoker. She smokes a half a pack per day and she's smoked for 40 years, so giving her a total of 20 pack years. She also has noted occasional marijuana use. Her vital signs are 142 over 88. Her pulse was 84. O2 sat was 98 on room air, and her temperature was 97.9 degrees Fahrenheit. So she had a cardiac stress test a month ago. It was negative, but it revealed more frequent unifocal PVCs with moderate activity. During that time, she also had an echocardiogram done, and it showed mild aortic stenosis with an EF of 55. Her 12 lead EKG shows a first degree AV block with inverted T waves in the lateral leads. But I looked back and there was no change from her baseline EKG. This has been her normal from the past few. Her labs were not significant. Her most recent BMP and CBC were all within normal limits, besides her LDL and her triglycerides were slightly elevated. Her pre-op pregnancy screen was also negative. For her airway assessment, she was a Mallampati 2. She had a temporomandibular distance greater than 3 finger breadths. Her upper lip bite test was normal, and she had a 5 centimeter inner incisor gap and full neck range of motion. She did have some loose and missing teeth, but all of her teeth were her own dentition. She's been NPO for 8 hours, except for she's had sips with her medication. For stop bang, she scored 4. She was positive for snoring. She's older than 50. She's reports tiredness and high blood pressure. She's been diagnosed with sleep apnea in the past, but she's non-compliant with her CPAP. Met score, she scored a 4. She's able to climb the stairs, but she's not able to do much more than that. Upon further questioning, I'd asked her about like when the last time she had taken her nitroglycerin, if she's experienced any chest pain. She has not. She hasn't needed to take that for greater than 6 months. But she just said that she's been pretty stagnant. So, she has had anesthesia in the past with no issues, and she did not know of any issues with anesthesia in her family history. So, with this surgery, the position that she'll be in, she's going to be in steep Trendelenburg and lithotomy. So, with these positions, cardiac wise, you'll see an initial auto transfusion from the legs when they raise the legs up, and that can mask hypovolemia. You'll see increased cardiac output and increased venous return to the heart. But this can also place the patient at risk for facial and laryngeal edema and post-op airway obstruction. So we want to make sure we do a leak test post-extubation. Also, with this surgery, they're going to be doing insufflation, so that'll decrease the venous return and increase the intra-abdominal pressure and SVR, which can lead to decreased cardiac output. It also places the patient at risk for pneumoperitoneum, and with that, we would see increases in end-tidal CO2. Also, we just want to make sure that we adequately pad her since she'll be in steep Trendelenburg using a non-sliding mattress and just being cognizant of positioning to prevent like a brachial plexus injury or anything like that. And with the stirrups and stuff, making sure that that's okay too to prevent nerve injuries. Main anesthetic concerns for this patient, insufflation, obviously, making note of what her baseline heart rate is, and if after induction it's kind of low, maybe having some glycopyrrolate drawn up before they actually do the insufflation. It's also important to communicate with the surgeon regarding like movement of the bed. I know a lot of times they can link the bed with the robot so they move together, but just communication is very important for the surgery. The surgery also has a pain score of 7, so we use some nice multimodal techniques and has the possibility of estimated blood loss for 100 to 800. So for her anesthetic plan, I decided to do a general anesthetic and use a tap block for multimodal pain relief and post-op pain relief. Intubation is preferred over supraglottic airway just because high increased risk of vomiting and aspiration with being a robotic procedure and the increase in intra-abdominal pressure. Also for the surgery, we require paralysis, so definitive airway is very ideal. For the tap block, I wanted to do ultrasound and use 10 milliliters of Exparil and 15 mLs of bupivacaine on each side of the abdomen, making sure to aspirate before instilling each 5 mLs. Also, having a bear hugger, a peripheral nerve stimulator, and placing an OG for gastric decompression just because of the high risk for aspiration. So, consent was obtained